2003, he showed his dedication to whole society as well as his leadership qualities. As a true follower of principles of Gita, he believed in karmanye vadikaraste ma phaleshu kadachana, doing karma without expectations of fruits. So he found joy and happiness in serving people. With all these activities and dedication, he continued to learn music and yoga as he believed in being a student for whole life. Though he is a teacher for many of us who taught us by the way he lived his life and not by lecturing. The legacy of his is continued with 3 doctors in the family and a wife dedicated to same principles as his.
So this is a legacy and which we are cherishing up to, and we hope all of us can live up to that legacy. And to give the oration on his name, we have Dr. Alok Modi. So he is going to give, his topic for the day is use of AI in medical practice. So to give a brief introduction about him, so he was a topper in internal medicine at KEM, and he's done his PG in lipidology with South Wales University, UK. He's an educator, he's a physician, innovator, and he brings us a bridge of medicine and technology. And he is going to talk about none other than the most important thing that we are discussing today is AI. And I would like to invite Dr. Roy Gaga and Dr. Utpal Sheth to please escort him onto the stage. Dr. Rohit. Oh, okay. So Pragna is here? Yeah, hi Pragna.
So good morning, everybody. At the outset, it's a real honor and pleasure. I'm coming here for the first time. And I got a call from Dr. Utpal and Dr. Utpal, Dr. Saurabh. I got a call from Dr. Saurabh actually. Dr. Saurabh, Dr. Utpal and Dr. Aarti ma'am. It's a big honor. I'm grateful to all of you and all the esteemed members of the scientific committee and the organizing committee for giving me this opportunity to be here. I'm very grateful to, since I'm giving an oration for Roy Gaga sir, I'm grateful to him and his family members for this wonderful honor. And before I start, I would like to give my regards to all the dignitaries who are present off the dais, and special thanks to my very dear friend, Dr. Ketan Mehta. He's sitting here. We have done our MD together, and I remember how we used to have our dinner with that pani wali dal in the mess in KEM during our residency days, and bonding starts from there. His wonderful daughter, my daughter, Dr. Nupur is here. So it's a real honor and pleasure. And before I start, I would like to just tell you guys one thing. Come down to Thane, and I hope our Thane association also, can get the flavor that you guys are running. So thank you very much for the invitation. My talk today is on AI, artificial intelligence. Before I start, let me clarify one thing. It is not a God's verdict or something. It is going to replace you with some kind of a glamorous heroine which has come into your life and you'll get everything done. ऐसा नहीं है. It is not artificial, it is additive intelligence or augmented intelligence. It can make a huge difference to your life, as I will show you right now. And जो मैं हमेशा humorously बोलता हूँ, शादी के भी side effects होते हैं, इसके भी side effects होते हैं. So you have to learn how to take it with a pinch of salt. So why am I giving this talk? And people ask me, am I a doctor or a technocrat? I'm not a technocrat, but yes, I'm certified by the American Board of AI for Healthcare Practitioners. I've cleared the Massachusetts and the IT exams. the last 2 years. So we have created our own solutions in AI, which I will show you, and you can also do that. There's a lot of work which is being done by AI, by medical practitioners. So I'm running a hospital and a diabetes center. I'm attached to Jupiter and KIMS, and I'm very much seeing patients like you people are seeing, and I'm also doing AI. So it's not that I'm a technocrat or an engineer. So I'm very much belonging to your community only. With that introduction in mind, there is no financial disclosure. Nobody's paying me anything for showing you these AI tools. And I create all my PowerPoints through AI, and you can see the amount of AI I use. I use practically everything on the planet. I don't stick to one wife or one tool. I mean, the former statement need not be true in real life. So I treat AI like a spouse, but then I use multiple AI solutions to get my work done, and that is the best way to go through AI. Am I better now? Okay, thanks. So let's understand basically what is AI. What does artificial intelligence mean? It's a very complicated topic, can't cover in 45 minutes. I'll try to make it very simple. So artificial intelligence is something which basically does what your neurons do. So when you were a kid and you were told some things, you got trained on it, right? So you realize this is my mom, this is my dad, this is my uncle, ye mere bua ji hai, ye mere masa hai, ye mere masi hai. And you are told ki this is my masi, not my mom. So AI has to be trained. When you train AI, ki so and so is the outcome, it learns and then it responds. So when a guest comes to your house, your kid will say, dad has come, mom has come, masi ji aayi hai, bua ji aayi hai, so the responses are different. So AI will respond depending on how you train. So it's a very intelligent thing. And before you get comfortable with AI, please remember, you will work with AI only when you treat AI with dignity, like a sentient, live human being. If you think it is a piece of technology, you will get frustrated. Because genuinely it is intelligent, it does things which you people do, sometimes better than what we and you can do. So it has decision-making capacities, it can learn. So when you work with AI, if you're using ChatGPT, for example, when you started using ChatGPT and after 2 years, how ChatGPT responds will be way different. So when you teach a child or somebody about some relations or the depth of human emotions and relations, that child will behave differently when it matures and grows up. So when your AI solution grows up, it behaves very differently. So my AI solutions behave very differently than what they were behaving 1 year back. So that is something you need to understand. So just logging into ChatGPT does not give you a solution to all the problems. It will give you a much better solution as you work with it. So you're realizing it's a very dynamic thing. It is not a static thing. Something that AI works upon is called NLP. How many of you know what is NLP? It's called natural language processing. So I hope you all can answer. If you can, then please do. So NLP is something very simple. So see, when you're working with a computer, you type 1, 2, it works on binary. So when you type the letter A, it is like 1001001. So the permutation and combination tells the computer it is letter A, letter Z, letter C, and so on. Whereas with AI, you can put in an image or a video, and you can get an answer. So a natural way of how you communicate with the atmosphere is how you communicate to an intelligent artificial being, and it gives you back. So Sora can create a video of you and your spouse, wife or husband, walking by the side of Ganges River at 5 p.m. on a monsoon night. It looks fantastically good. That computers cannot do. That is NLP, natural language processing. What is a real life example? Very, very simple thing. Now you guys have got Aadhaar card, right? Aadhaar card is coming in very soon. I have my Aadhaar card. You all can also create under the EBDM scheme. The government is going to make it mandatory through insurance very soon. So if a patient of yours has visited Fortis Delhi, has come to Ambani Hospital in Mumbai, has come to Max Nanavati, has now come to you, he's got some 10 files. How can you go through all the files and make sense of what's going on? So NLP goes through all that thing, makes crystallized one-page reports and tell you what is relevant in that patient, which you can see and go ahead. So that natural language processing can scan textbooks and volumes and literature and all and give you data what is relevant, intellectually, scientifically accurate, on which you can work. And your patient can control what data should be given to which bariatric surgeon, to which physician, to which gynecologist. You may not have access to all that. So that is natural language processing. It has tremendous implications in research, in pathology reports, histopath reports, and things. You get the idea. The only thing which I'm trying to do is I'm not going to teach you AI. I'm going to seduce all of you so that you can get into AI and then you can take formal training on AI, because I cannot cover AI in 45 minutes. What is a neural network? So just as you have your brain, you have a lot of synapses. So one neuron communicates with the other neuron and so on and so on. So there are algorithms which communicate one after the other, and we fondly call them neural networks. So they talk to each other. One layer goes to second layer, to third layer, and fourth layer, and you get an output. How does it work? It works like this. So if you see this, the AI is told ki so and so is a cat. So there are multiple layers by which AI understands ki the word cat equals to this image. So every time we put that image, AI will say it is a cat, it will not say it's a dog. So when you see an MRI report, it knows there is an infarct or a bleed. When you put a histopath report, it can actually diagnose ki yes, there is cancer in the breast. When you put in a chest X-ray, AIMS has started reporting X-rays to AI, as you must be aware of. QXR is there in Nanavati Hospital. I think the previous esteemed speaker was from Nanavati. They're reporting all their X-rays to QXR, which is an Indian startup which is doing X-ray reporting. So I can very accurately pick up lesions. They can pick up retinopathy lesions and tell you that this is a non-proliferative diabetic retinopathy, which is to the tune of accuracy of 98 to 99%. That is how a neural network works. And as the picture changes, like when you're working with antimicrobial resistance, so like, so far we are working with microbial resistance, we collect last 1 year data in a big corporate hospital, say, these antibiotics were resistant to these organisms. So the next set of antibiotics, empirically, when a patient walks into the ICU, should be probably doxycycline and probably augmentin, and not piperacillin, tazobactam, or amikacin, or levofloxacin. Based upon the 6 months report, AI says, no, that should not be the thing. Evidence-based medicine is a thing of the past. It is a data-based medicine. So what data you have, AI can create projections and give you answers to that, and give you what should be the next set of antibiotics. And this is what is being done in Mayo Clinic with a fantastic outcome. And this data changes over a period of time. So the data, when it changes, you have created an AI model, it keeps changing itself and self-runs. That is what is called as a liquid network. So a liquid network is a set of neuronal network which trains itself over a period of time, which is what your ChatGPT and Perplexity and Claudes are doing. And it changes its outcome as you work with it. So that is called LLM. Tokenization is very simple. So when I read a book, so when I'm reading a book, there is the cat chased the mouse. And that statement comes 100 times in the book. So I cannot keep wasting my time reading that same statement. So tokenization splits cat, mouse, chases, and makes how many words are there in the book and makes it into 3 words. So the entire book is split up into 1 or 2 chapters. And these are called tokens. So it communicates via tokens, which are essential. And the speed of the whole process of reading the book is reduced in less than 1 minute. So when you have the real life application is when you're working with Supreme Court or High Court document which run in 5,000 and 10,000 pages for a corporate, they crystallize the whole thing in less than a minute and tell you what is relevant. That's how you get summaries. So when you're reading a journal, so if you're going Google Notebook LLM, if you're using it, I create a lot of podcasts. You can create a podcast out of some. So like Dr. Ketan is writing a lot of articles. He's published 10 wonderful research articles yesterday. So a humble request if you can. So if you can, see, let's say Dr. Ketan has published 10 research articles, and I don't have the time to go through, but they are worth reading. It's because Ketan Mehta has written it. So I converted it to a podcast of 5 minutes. I can complete 10 articles of his in 5 minutes while I'm taking my coffee and I'm driving my car to Jupiter Hospital. My work is done. That is what happens with tokenization. So this is how a network looks like in an AI, and this is how it works. Now, I'll give you another example. Let's say I'm an assistant to Dr. Ketan Mehta. I've joined his hospital. I've joined Suchak Hospital. He's doing a fantastic job. But I don't understand, for a negative PS for MP and a negative dengue report, why does he treat them as dengue and malaria? So I feel something is wrong here. The reports are negative, but Firbi is treating them as dengue and malaria. Why? He's not wrong. I don't have knowledge. I've got my MBBS MD degrees in place, but I don't have the reality of knowledge, which is it. So he has to teach me that the platelet count is low, the MP report is negative, dengue NS1 is negative, yet he can have dengue, so you have to treat him before he collapses or he dies in the ICU. So that kind of training is called prompting. So I'm an intelligent, learned being, but I have to be prompted. So if I don't take the right prompt, I would learn. So what happens? He tells me, platelet come hua to start treating. So I've got a patient of idiopathic thrombocytic purpura, I'll start giving him anti-dengue medicine, which is wrong, no? So I have to be prompted properly. So you have to talk to AI in a proper manner. If you don't talk to a proper manner, you'll get all kind of garbage from your AI. That's called hallucinations, or that's called GIGO. Garbage in, garbage out. These are official technical terms. A hallucination is not a psychiatric term. These are official AI languages which I'm using. So unless you teach your AI properly, a huge change in the outcome comes, and that is called prompt engineering. So you have to learn how to prompt an AI. So do you know people who are trained in prompt engineering? Can anybody tell me how much salary are they drawing today in Mumbai city per month? Any idea? 1 crore? 1 crore per month? Then Ambanis will have problem with him. Not so much, ma'am. I wish you were true. I would have shifted gears today only. Somewhere from 5 lakhs to 25 lakhs per month. So you all can think, tomorrow you may not be here. You can start doing something else. Seriously think about it. Probably, and anyway, we are running it. So the point is, this is from, so when I was doing the course for Massachusetts University, I was given a capstone project. So I was told about Ola and Uber, I was given data about which drivers have the highest rating, which customers are most loyal, which avenues have the maximum traffic, which seasons have more traffic, which time of the day has more car output, and which time of the day has less car output, which corporates have bigger demands than other corporates. I have to increase the business by 25% or to create a model which will give Ola and Uber a better output by 25% more. And that is how I prompt that data and the AI tools to work. So you understand the role of prompt engineering. The entire business can go haywire if the prompt engineer does not give the right prompt. And the reason you people get frustrated with AI is because you don't give the right prompt. So when I asked ChatGPT, what is the EGFR of this patient, says 1200. 1200 का EGFR किधर होता है? हाथी का भी नहीं होता है. So that is where a wrong prompt comes. So this is prompt. So prompt has to be, जो BNI में हमको सिखाते हैं ना, I don't know how many of you are BNI members, specific is terrific. So the more specific you are with your prompt, the more terrific your outcomes would be. So coming back to the example, Ketan taught me very specifically, if these parameters are present, it is always dengue. Treat it as a dengue even if NS1 is negative. If he didn't give me that prompt, I would not become a better assistant to Ketan. नाम मैं Ketan का ही खराब करूँगा, मेरा नाम नहीं खराब होगा. So that is where prompt engineering comes into place. So specific context, constraints, evaluation, relevance, right way to write. Sometimes I have written prompts which run into 5 pages, and I'll show you the outcome and the difference in the outcome. Whereas if you have a very vague prompt, patient has HbA1c 12, fasting of 200, post-lunch of 300, blood pressure 170 by 100, give me the way to treat this patient. It's a third-class prompt, you'll get a third-class answer. So you have to be very specific. Now I'll give you a real life example. So I was buying a car. So I asked ChatGPT कि I want to buy a car. Garage वाले ने मतलब डीलर ने मुझे ये डील दिया है कि ये EMI रहेगा, ये डाउन पेमेंट रहेगा और ये 5 साल का ये है. What do you think? I should go for this deal or not? I told कि you're the car dealer. He said the best deal in the market. You cannot even think of something better than this. And I said now you're my bank you're my bank manager and you're my financial advisor. It is the third class deal is making a fool out of you. Don't play that EMI. He's charging you in advance. So the moment you define the role, you tell ChatGPT you are a postgraduate PhD academician writing a paper, the outcome of the paper will be very different than when you tell ChatGPT I want to write a paper on postpartum hemorrhage, since Dr. Saurabh is here. So that will be a very different paper. So how you write the prompt makes a lot of difference. Now I'll give you a prompt. I'll show you a prompt. Let's see. This is a prompt where I gave, make an Instagram post to promote my hospital, make it viral, add catchy lines, emojis, and a lot of hashtags. You see what kind of output I'm getting. You think this is something I can put on LinkedIn or Insta? This is the output I'm getting. Now, I give a prompt. Now, let me show you the prompt. And I wrote a prompt to ChatGPT. Now, these are actual examples. I've given the details of the prompt. As you can see, what is the audience, where is my hospital located, what are emergency numbers, what I want, how am I looking, what hashtags I want. So it's not कि ChatGPT हाथ में आ गया तो you've married a Hollywood personality and your life is made. It doesn't work that way. There is nothing like a free lunch. सब जगह मेहनत करनी पड़ती है. So you see, this is the prompt I'm writing. And see, having written this prompt, what happens next? This is the output I'm getting. I get a very good output. I get a button where I can click and dial the hospital. I can get a booking appointment calendar and all. Everything comes out just because I've written 5 extra lines. So you understood the role of prompt engineering. So if you want to work with AI, you have to learn how to write a prompt. Now let me, yesterday I was giving a talk in anal fistula in FistulaCon, which is running, it's running today also. So I created this prompt for them to show them how a paper on anal fistula can be written. All of you, many of you must be writing, and Ketan is very happy to sit here to listen to this because it's बहुत काम की चीज़ है. How to write an academic paper to be published in an international journal. So we are writing this paper on anal fistula. So I've given a prompt, kindly generate a 5,000 word article on anal fistula. So see, I've written that prompt I've given to ChatGPT कि भैया लिख दो उठा के. So it is writing. So the moment I write, see, this is the paper which comes out. One second. So it starts writing the paper, and like magic, the entire paper starts flowing. So you see, the moment it starts thinking, ChatGPT is thinking. Now it has started writing the paper. It is thought, now it has started writing the paper. So your paper is flowing. You see the magic happening. Abstract, introduction, etiology and pathogenesis. Everything comes out so beautifully. You say, "Mera paper to taiyar ho gaya in 5 minutes. What is wrong with it?" The wrong is this, the references are 2036, 2029, 2080. You think a journal will accept this? And there will be article, sentences written that anal fistula can occurs better in an animal than in a human being. Why, you know? Because ChatGPT, Perplexity, and Grok are generic LLPs. LLMs. LLMs are large language model. Why is it? I'll tell you this. Few years back, Sundar Pichai, I hope you guys know Sundar Pichai, he was called to the American Parliament and he was asked this question, कि the moment somebody types the word idiot on your Google search, किसी एक आदमी का photo आता है, you know किसका photo आता है? The current president of the United States of America. He said, उसका photo क्यों आता है? What nonsense are you guys doing? You want to stay in this country or not? He said, मेरी गलती नहीं है. Public ने जैसा link किया वैसा Google दिखा रहा है. I'm not doing anything here. So ChatGPT picks up from all the internet researches which are going on for the last 50 years. So the moment you write an article on headache, it will write 99% it is always brain cancer, which cannot come from your table. No? That's wrong. You're a certified medical practitioner. Because it is picking up anything under the earth which is there on the internet. But the moment you put 20 research articles in ChatGPT and says, restrict your knowledge to these 20 articles from PubMed and Google Scholar, do not seek knowledge outside these articles, the whole research paper changes its tune. Understood? So, and then you have to write, I want to publish this paper in Lancet or any JM. So kindly tune your paper like that. AI language should be less than 10%. Plagiarism should be less than 4%. It should have a human touch and a human emotion, which sounds like Dr. Alok Modi has written or Dr. Ketan Mehta has written. The moment I say Ketan Mehta, it will reach the last 50 articles of Ketan Mehta and turn it accordingly. When I say Alok Modi, it will write it like Alok Modi has written. You understood how things are done. I don't want to reveal more secrets than this. नहीं तो मेरी paid classes के लिए नहीं आओगे. But this is how a good prompt makes a difference. So you can see I've written this prompt which runs in 3 pages, and having used this prompt which I have created, this is the kind of articles that are coming out. See, I'll just come back to that. This is the kind of publications that are coming out. See, this has been recently published in International Journal of Hypertension. Dr. Anuj Maheshwari, who is the current president of RSSDI, is a co-author here. This is an article which has just been published 1 month back in International Journal of Diabetes and Technology. This is an article which has got published in Journal of Diabetes Research Reviews and Reports, and this was a presentation in ADA 2025 for which we got the best award also. This is the article which me and Dr. Ketan Mehta have written together. He is sitting right in front of you. Air pollution and cancer. We have contributed to this chapter. Again, it was written through AI. And this is the latest article which I have written on role of quantum computing influencing artificial intelligence in healthcare. Now that is the next thing. AI is going to be redundant within 3 years. You're getting into quantum mechanics. I'll come to that later. So this is the kind of an article which comes out and gets accepted in international journals, though it's written by AI, because the quality of the article is very different. Now if you look at this, PowerPoint. Now you see the PowerPoint that I'm presenting today, and all the PowerPoints that I present and many other PowerPoints that are presented by many people are created by me, is created with AI. Can you see the kind of output? You think you can create an image like this? And how much time do I take to create this kind of an image? Not even 10 seconds. So literally, you know, gentlemen like Ketan tell me, "Arey Alok, I need a PowerPoint." देगा क्या कभी आज 2 बजे करना है, ठीक है, अब तू 12 बजे बोल रहा है, ठीक है, लेकिन 12:30 तक उनके डेस्कटॉप पे पहुंच जाता है. And it's a smashing PowerPoint. That is the power of AI. Ketan, sorry. Though he's never asked me for it, I'm using him as a guinea pig. So this is the thing. With AI, you can create the output, the content, the thing. But your PowerPoint generated by AI can be all nonsense because you're asking AI to pick up the educational material. So if you tell AI, these are the 20 articles on which I want you to base my PowerPoint, the content of the PowerPoint changes. So it's how you use AI which is important. We do biostatistics through AI. So these are some of the tools that I use. And these are some of the tools, like if you use IBM Watson, which I'm using to review many journals. This costs you around $3,500 per month. So I'm using Julius AI and GitHub, which needs a lot of knowledge of Python. So I'm literally doing biostatistics from the top academicians of the country, and we are publishing a lot of papers in international journals by using. So you have your own data, your own gynecology data, your own surgical data. You have done 500 bariatric surgeries. You have done 5,000 hysterectomies in your clinic. You want to publish a paper. You want to analyze that data. You go to a statistician who uses SPSS and charges you 25,000, or some pharma company has to do it for you, whatever. You can use an AI tool, which I'm using in 15 minutes flat, you have data which you can churn for 5 lakh patients in 15 minutes, and the kind of analysis is totally different. So let me tell you what that analysis is, something called as random forest and ensemble. What is that? Now, this is called clinical decision support system, which Mayo Clinic is using very regularly. For example, I've got a patient with pneumonia who's not yet on a ventilator, whose creatinine is 0.9. After 5 days, he goes into sepsis, creatinine becomes 1.8, he goes on a ventilator, and procalcitonin is 6.4. Now, all this can be created by AI, can tell me that this is the patient, so start these antibiotics, do this kind of an oxygen system, do this kind of a management, so that he doesn't land up into sepsis. This is called clinical decision support system. So suppose you start using that system in your clinic, can you imagine the output of your patient will be so different? So the CDSS is something which is a big thing in AI, and that is called random forest analysis. What that means is, there is a tree in a forest. So you put the data in the tree, and the tree says, if this is a scenario, you do this, this, this. This is a random forest. Suppose multiple trees give you that answer, so it becomes a random forest. So if you collect the data from all the trees, can you imagine the quality of your output? So when you admit this patient in a corporate hospital, it is 5 Ketan Mehtas and 5 Alok Modi seeing the patient. So the treatment is very different, right? Because it's a collective brain of everybody deciding the treatment. But suppose one Ketan Mehta sees, and Alok Modi says, no, no, isme thoda changes karte hain. And then the second Ketan Mehta sees, and then the third Alok Modi sees. By the time the final Ketan Mehta sees, the treatment is totally purified and fantastic. So when one tree sees the other tree sees the other tree, then finally you get an ensemble, the clinical decision support system is way beyond your imagination. That is the kind of biostatistics that AI does, which nobody can do. You're getting an idea? I'm just touching you on the topics. So you've seen that movie of Tom Cruise called Minority Report, where they could predict murders before it's happening. With AI, I can predict in your area in Kandivali, how many will become diabetic and hypertensive in your clinic after 5 years. How many of your patients who are not diabetic today can become diabetic after 3 years? I can accurately predict through AI, which no other tool can do. This is the kind of biostatistics, and suppose you can do that and publish a paper. Can you imagine where your paper production would go into? What kind of research you're doing? This is what we are doing in real life. This is the kind of data that we are working with. Now, is it only with research and all? Let me give you some other things. You can use it to do so many other things. Let me show you what I can do. So this is a live video I want to see. So I filed my tax returns. So you create your tax returns to your CA. Try to take your computation sheet and put it on ChatGPT with proper prompting. It will tell you 15 mistakes where you are wasting your money. It can tell you which sections you can invest so you get a better outcome. And believe me, you can probably save 50,000 rupees because of ChatGPT. Kitna paisa bhar rahe ho uske liye? $20 per month, that's it. It's a reality. Huh? We have created GPTs by which you can decide which are the leading shares in the market and where investment will fetch you more returns. It can be wrong, huh? But it gives you outcomes which finance managers cannot also give you, provided you know how to prompt your ChatGPT. So these are some of the real life situations where you can use other than academics, and I'm sure everybody here is highly interested in this aspect of AI. So if you can see this, you can see it can tell you that these are the areas where your tax returns were filed wrongly, and these are the areas where you can tax return can make a huge amount of difference. You can end up saving a lot of money. Now I'm also on the editorial board of International Journal of Diabetes in Developing Countries, and to do that I get some 25 articles every day or 10 articles to review, like Dr. Ketan Mehta also gets. So poor Ketan Mehta sits and reads that entire article in detail for half an hour and writes कि यहाँ पे गड़बड़ है, ये करना है. आलोक मोदी उसी आर्टिकल को 3 मिनट में निकालता है. With much more detail, because of this GPT which I have created, it analyzes the entire article, checks for plagiarism, checks for literature review, checks for Vancouver format, DOI, checks for the clinical relevance, checks the statistics, give me a summary where things are wrong, whether it needs a major revision or minor revision. I can see a lot of smile on Dr. Nupur Mehta's face. So this is how an AI can work, but it is not Alok Modi's review, this is AI's review. So to be ethical, you need to go through the review and then finally finalize what should be your outcome to the journal, because you are responsible to the journal, not ChatGPT. So AI is not here to replace you or become a glamorous tool for you, but it does 80% of your work. The remaining 20% you can handle on your own. So suppose that 80% work was done by you, can you imagine where it would be? So today what is happening is, when a patient walks into your clinic and we are running that system, the receptionist takes an interview, आपको खांसी है, कब से है, कितने दिनों से है, पीला बलगम जाता है, सफेद जाता है, हरा जाता है, अच्छा, छाती में दर्द होता है या नहीं होता है, सांस लेने को कितनी तकलीफ होती है. After 15 such questions which a non-medical person, 12th pass receptionist is taking, it creates a differential diagnosis, treatment outcome and diagnosis and sends it on my table, which only I can see, the receptionist and patient cannot see because of data security. So I know this is a potential tracheobronchitis. I know what to give. I will ask the questions, but can you imagine the amount of time that I've saved here? And the whole prescription is pre-generated because of AI. And whether the patient talks in Hindi, Marathi, Sanskrit, Telugu or Pakistani or whatever language, it doesn't matter. AI को फर्क नहीं पड़ता है. The prescription is ready in English. And this is happening in real life today. So when I talk to the patient, I'm not tuck, 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 tuck. I'm, hi, Saurabh સાહેબ કેમ છો? મજામાં? અચ્છા, ખાંસી થઈ ગઈ છે? અચ્છા, અચ્છા, bronchitis લગે છે. ઠીક है. હું કરીશ, તમે બસો જરા. Done. He is very happy. Dr. Modi is so good यार, मेरे कंधे पे हाथ रख के मुझसे बात किया, लेकिन पूरा मसाला तो रेडी है मेरे सामने. Otherwise, there was a jamana when EHRs were launched, and I was typing, and patient literally, I am in Godbandha Road area where I am practicing. Patients have told my manager, त्या डॉक्टरला काय येत नाही, तो नुसतं कम्प्युटर त्याला काय दाखवतो, तोच प्रिंटआउट काढतो, त्याला स्वतःला काय येत नाही. तो फक्त टकटक करतो, कम्प्युटर त्याला सांगतो की हे आजार आहे, म्हणून तो ट्रीटमेंट देतो. तर बरोबर आहे ना, डॉक्टरला नॉलेज वाटत नाहीये, कम्प्युटर करून शिकतो तो. So see, this is what happens when you don't have an eye-to-eye contact with a patient. This is where AI makes a huge amount of difference. Now I've given you a lot of good things about AI. Like I said, marriage के भी side effects होते हैं. So having covered all this, let's come to something which is important, which is the relevance of AI in healthcare, how relevant it is and how prudent it is and how ethical it is, and what is the law about it. So we just published this editorial, me and Dr. Kulkarni, on the responsible use of artificial intelligence in clinical medicine. So I was just telling Dr. Bijal ma'am a few days back, I can have an affair and I can have a marriage with a girl. Both are good-looking girls. I don't have an affair, by the way, just for your clarification, except with a laptop. My wife says I've got 5 southerns. There are 2 laptops and 3 mobiles. So those are a different affair which I love to have. So anyway, bottom line is ki, if you're having an affair, you're interested in that girl, and I'm not gender specific, even ladies can have an affair, and why should they not have why only guys should have an affair? So if you're having an affair with a guy or a girl, and whatever it is, you're not interested in the family. But the moment you get married, you cannot say I'm married to a girl or a boy, I'm married to a family. So your mother-in-law, your father-in-law, your brother-in-law, your sister-in-law occupy the same place in your life that your own brother and your own sister and your own parents occupy. And if you do not have a sense of responsibility towards your spouse's family, then your marriage cannot be successful. Correct? Even if you gift a diamond necklace to your wife or your husband every month. So that responsibility is there. So AI is like a wonderful spouse, a very glamorous spouse. But then you need to have a responsible attitude when you're using AI. And how do you use that is where things go wrong. And you need to understand what are the ethical and legal considerations. And there are 5 pillars. This is a wonderful article by WHO, 300-page document which has come out. There are 5 pillars. AI is highly biased. AI is not liable. AI has no security. AI is giving you inequality of wealth. The company which makes AI decides which patients will get the benefit because उनको उनका फायदा देखना है, आपका नहीं देखना है. And who controls the AI solution in your clinic? Today, insurance company decides how your patient should be treated, which is something we don't like. Tomorrow, an AI solution will decide how your diabetes patient should be treated, how your gynec patient should be treated, how your surgery should be done. If the robotic company decides how your robotic surgery should be performed and when it should be performed, it is breaking the nuances of medical science. So this is a paper that I recently published, the role of artificial intelligence in healthcare. There are so many AIs which are rushing to create an AI solution for healthcare. And in this competition, a lot of jargon has already started coming in, and healthcare is getting biased. So there are a lot of concern about inaccurate responses. So suppose I depend on an AI to decide which antibiotics to be given to my ICU patient, and suppose that decision is wrong, who will face the music? I can have a data quality. I've trained that AI in US, Tanzania. That is not the same spectrum in Kandivali, right? I bought a solution from US saying this is the best ICU solution in Israel. It cannot be copied pasted in Kandivali or in Godbandha Road in Thane or in Mumbai. You have no knowledge about the pathogens in this area, right? So how can you copy that? So data quality and privacy. Automation bias. We are so used to carrying ChatGPT in our pocket that we open up, take a photo. Acha, ye chamdi mein lesion hai, fine. This is what purpura erythemans. Fine, fine. So this is the thing. Arey, but who told you not to use your brain? You're a qualified dermatologist. How do you depend on AI to say ki, what is the lesion? So AI said this is our LSCS should not be done. And then Dr. Saurabh realized the last moment LS should have been done 15 days back. Now how do I handle this? So dependence on AI and automation bias is a very bad thing, and a very important thing that medical legal people will know very nicely about informed consent. Today, when a patient walks into your clinic, it is an implied consent. You don't take a written consent. But for every procedure, you are supposed to take a proper consent. And there was a case in RG Stone, which I will be happy to take because it's in public domain, where the consent form was not accepted by the National Consumer Forum because the consent was a pre-printed form. The law says that the consent has to be individual, should be explained, and has to be individualized for that patient. So do you take pains to explain to your patient, I'm using ChatGPT to make your diagnosis? If you don't do that, you're on the wrong side of the law. At the same time, if you do not use an AI because you feel it can put me into trouble and patient gets a better outcome, he can take you to court tomorrow. What prevented you from using AI and compromising on my care? So it's a double-edged sword, and we don't have an answer yet because there is no law on the planet which specifies this right now because we are in the infancy stage. So I'll share one case with me. My patient had diabetes. 6 months back with 300 and 400 of fasting and post-lunch. I treated him, he got better in 1 month, and they decided, as is the usual case, allopathic medicines are bad for health. They shifted to an Ayurvedic pattern of treatment and they disappeared. Fine, that is their decision. After 6 months, they came back to me with a little gastric disturbance, gas hota hai. They visited a gastroenterologist who said, kuch nahi, gas hai, gave them Gaviscon syrup and pantoprazole. Then they went to 3 cardiologists thinking ki koi chest pain to nahi, no? Those Godbandar people are little educated people. So 3 DM cardiologists did an analysis, did an ECG and 2D echo, which was normal. Sent them back. They came to me. I said, सब लोग गलत तो नहीं हो सकते, उसके symptom क्यों नहीं जा रहे? Put the ECG in an AI solution, and it said it is a non-ST myocardial infarction. Patient had come to me 4 days late, so thrombolysis could not be done. There were 3 stents put in that patient on angiography. This only AI can pick up, and this is a separate article journal of NEJM, which is one of the most reputed journals. They're running an AI journal where it is clearly shown that there are so many databases which have shown clearly that the top-notch cardiologists are not able to pick up MIs and arrhythmias because of a flat line which a human eye cannot discern, which an AI can pick up. So the question is whether you're using AI or not using AI, who takes the call? And who will take the consent? And if you use AI, you could have a vicarious responsibility. And if you do not use an AI, again, you can have a vicarious responsibility. The law is not very clear about it. But that is a tricky situation that we will be facing tomorrow. What about the doctor-patient relationship because of straining? Today, we have a Google patient, and you know what pains they are. And tomorrow, you'll have a ChatGPT patient, and already you must be getting such patients. How does it impair your doctor-patient relationship? Where does the ethics take you over there? What about inaccurate, false, biased responses by AI? And what about the data quality on which you're training? So you have trained AI on a set of 50,000 X-rays 2 years back. You have not upgraded your model. How do you know that the X-ray pattern has not changed in your area? How do you know that the community acquired pneumonia or tuberculosis pattern has not changed? So the data quality and fairness is not there in many solutions. And automation bias is a big pain in the neck because every teaching hospital doctor knows that the residents do not enter the wards. They just use AI to make their diagnosis, give their exams and come out with their degrees. And they don't even know what is going on in the wards in real life. So an AI can take away your bias, and a seasoned medical practitioner who gets dependent on an AI solution will stop using his brains to make a diagnosis and differential therapy options for your patient and ignore his own knowledge, which leads to skill degradation, which has already started happening because of over-dependence on AI. Informed consent I've already covered. So these are some of the issues that come with AI, and there is something called as a distributional shift. There is something called as a temporal shift. So the pattern of antibiotic resistance that you see today may not be the same pattern after 3 years. So the data has to be re-evaluated, retrained, and recertified, which may not happen. So your own AI solution, your own EHR and EMR gets useless after 2 to 3 years, but nobody takes pains to upgrade it. That is called distributional shift. There's something called as saliency. Now, salience is a big term in AI where they found a model where the US Armed Forces took multiple photographs where they hit soldiers, and they could pick up that these soldiers are the ones who have to be targeted, they're enemy soldiers. So one algorithm picked up trees as soldiers, and another algorithm picked up soldiers as trees. And the outcome was different because the training model depended on who trained the solution. So a lot of training biases are also there. I'm getting signals to shut off, so I'll shut off very soon. But before I leave, I want you to listen to this. This is something which is a little breaker. So I just want you to play this, and I hope the volume can be heightened. Kindly just listen to this. So did you like that? So the lyrics, the words were mine. I have written that and I write a lot of poems. But the entire music and the song was created by AI. So this is what I do in the evening time. Many doctors take a bottle of alcohol, I take my laptop. That's why my wife says, Meri saute. And I create a lot of bands and I'm going to launch my YouTube channel very soon on multiple such things. So believe me, the kind of output you get is huge. So I would encourage you to be part of this program called AI for Healthcare, and this is SHIFT that we have founded. So a couple of endos from across India, we have come together to form this SHIFT organization, and I'm happy to share that we are incubated by NASCOM. We have been approved by the government of Gujarat. We've already come out with a medico-legal tool which is approved by the National Law University of Gujarat called Juris Medica. We would be formally launching in the hands of the Honorary Prime Minister very soon, and that's going to be a tool which will help you people understand what medico-legal issues you can face if you have a patient who's a potential lawsuit patient and can tell your lawyer what medical things he needs to understand before he just follows the bolums or whatever the legal principles to that case. So it is an idea trying to bridge, reduce the medico-legal implications for a healthcare practitioner, because most of us actually don't purposely do wrong things, but then since you don't know law, you're on the wrong side of the law and vice versa. So this is an effort in that direction to help people from both the parties so that the ecosystem of us, that is the patient, gets the maximum benefit. So these are the QR codes. You can scan these codes, become part of it. We don't expect you to learn from us. We believe all of us are highly learned. You all can share your knowledge, your tools. There are some doctors who have created such wonderful AI solutions which are being used today. One of the doctors from Gujarat has created an entire operating system for Android phone which is working very well, and Samsung has been privy to that. So a lot of doctors actually come out with some wonderful solutions. So join up. AI is the future of tomorrow. We always say that AI will not replace doctors. An AI trained doctor will replace a doctor tomorrow, but AI cannot replace a doctor, because remember one thing, it is a human in the loop and not AI in the loop. Decisions have to be taken by you. No AI can place a hand on a patient's shoulder and say, I'll take care of it. That only you can do. Only you can comfort a patient, and AI solution cannot comfort a patient. So you're always at the end of the tunnel, as a light of the tunnel. Let's not forget that. The center of our ecosystem is the patient, and the head of the ecosystem is you. Your own clinic, your own hospital, you as a medical practitioner is the highest authority. But AI is here to add to your knowledge, augment to your knowledge and experience, and let's get into that and deliver better patient care tomorrow. I have not covered the DPDP Act, which has just undergone revisions in the last 4 months. There is a lot of changes. Time is short, so I won't cover it. But the whole purpose of this oration was to tell you that AI is here. Try to learn AI to the best of your ability and be a part of the system, because that will be the in thing tomorrow. And very soon there will be official classes. I'm one of the faculties in MUGS, which I'm going to be training people on AI formally and officially. So it's going to come up as a degree course very soon in the next 3 to 4 years. So I would implore and request all of you to understand it. It is something wonderful. The day you fall into it, maybe I will be listening to your talk when you're coming here. It's such a wonderful thing. So get into it. And before I get out from here, thank you very much to all the respected members of this association for giving me this opportunity. I hope I've not put you guys to sleep. It was a big honor for me to come here, and I'm very grateful to all of you. Thank you very much.
Thank you so much. So the lyrics were beautiful, but we really have to mention the life which you have really put in the lyrics while presenting this song. Now I request President Dr. Utpal Seth, General Secretary Dr. Saurabh Dani, and Dr. Rohit Raigaga. So please come and felicitate our orator. I request the stage team to please assist us. So as I said, we should go on clapping because we make some atmosphere in the hall. So we charge up as well ourselves when we clap our hands.
I'll just read this. Yeah. So I'll just read the plaque we are presenting. So Kandivali Medical Association presents the plaque to Dr. Alok Modi in appreciation of his distinguished oration on use and misuse of AI in clinical practice, delivered at the Biennial Scientific Conference, KMACON 2026.
So please. AI has conveyed your message to him. So please. So I request all the dignitaries to please have your seats. Yeah. So now here we end the inaugural and the oration ceremony. So of course the sessions will continue in the Hall A and Hall B as well as planned. And before we move on to the next speaker, I really want to thank our sponsors. All the events are incomplete if there are no support of the sponsors. For that, I would like to thank United Hospital, Dr. Vinod Birajdar, who has sponsored the welcome kits. Secondly, I want to thank Altius, Dr. Bhushan Keskar, Dr. Deepak Rasil, for having us this first fastest finger fist gifts. And the delegate gifts, the co-sponsor is Sunflower Labs, Dr. Vipul Patel. So AV team, can we move on to the speaker now? So it's again an honor, pleasure to see Dr. Rajani sir here on the dais. So whenever he's there on the dais, you know, all the neurons are fired, that's what he says. Today he was here with us.
Are not fired but activated.
Activating. And he always said that if you have more of a spice in your life, you'll never grow older. So this he told me once when I was eating a lot of spicy things and somebody told me, don't eat so spicy. He said, nahi, spicy khana chahiye, you'll remain young forever. So I really admire that. So we all know that sir is a practicing neurologist and founder at WINS Hospital, Borivali West. He keeps special interest in epilepsy, stroke, and treating headaches. He is practicing in Borivali for more than 20 to 25 years. Sir is here today to talk about heavyweight, high risk. How do we rationally manage the stroke in the obese patients?
Video as well. Connected?
No quiz. So I think the slides are ready.
Okay.
So let's welcome with a big round of applause Dr. Rajani sir.
Connect नहीं हुआ? आ गया। हाँ, ठीक है। ला मैं हाँ, ठीक है। Thank you. Connect किया इसको जो है ना इसके साथ में। Good morning, everybody. It's nice to be again back with you and to speak about one aspect of neurology which is very close to my heart. This is not just a theoretical lecture, it's actually something which is very, very important. And why it is important and what we can do about it, and there is a very important role for you people also. Therefore, I try to speak about these aspects of stroke in front of you because there is a very big role to be played by you people also in picking up the stroke early because it can make hell of a difference. It may be the most important intervention which has to be done. So as you know, stroke, see, is a third largest killer in the world. And more than the mortality, it is the morbidity also which is associated with the stroke is very important. And this becomes especially very, very important in obese people. Because see, if a lean and thin patient develops a stroke, becomes hemiparetic, then it's easier to manage that patient, do physiotherapy, do nursing care. But when obese people, they develop a disabling stroke, then it becomes very difficult for the doctors to treat them, for the patient to recover. So it ultimately compromises the recovery also a lot. So obese patients getting a stroke, presents a special challenge to neurologists and the treating physicians. So I will be dwelling mainly on stroke plus the aspects of stroke which are different in obese people, how we have to modify our treatment, what further can be done for obese people so that we get a good outcome. So as you know, stroke is the largest killer after ischemic heart disease and neoplasms. And it is said that around more than 1.5 million people are getting affected by stroke in India. I think the number may be even higher. And many of the patients who are getting stroke are young people who are in the prime of their life. And once they get a stroke, they may get disabled for life. They may not be able to pursue their vocation. They may become dependent on the family. The breadwinner may lose the ability to pursue his profession and become dependent on his family. So he may become a burden on himself, on the family, on the society. So what can be done so that this scenario does not emerge? So there has been a lot of advancements which has been taking place in the field of stroke, which have made the prognosis of these patients much better as compared to 25 years back when I started my practice. When I started my practice, there were no modalities like this which are coming now, and this used to be just aspirin and physiotherapy and nootropill. That was the treatment of stroke at that point of time. But there's been a lot of advancements, especially in the field of ischemic stroke, which has actually materially changed the outlook. But the most important thing is that stroke has to be picked on time, and the intervention should be done in time. Then only all these newer treatments can help the patient. So as you know, stroke is the commonest neurological emergency, and it is because of a vascular pathology. So this is very, very important to understand that stroke is a neurological problem which has got a vascular basis. This is very, very important to understand. Why it is important to understand? Because the size of the artery and the place where the stroke has happened will decide the clinical outcomes, plus what we should do, how we should treat the patient. That also depends on the vascular pathology. So this is a very important point to be made, that stroke is basically a neurological problem due to vascular problem, either ischemic or hemorrhagic. So we'll be looking into this in greater detail in the next few minutes. So what are the common modifiable risk factors for stroke? As you know all, hypertension, diabetes, dyslipidemia, cardiac abnormalities, alcohol and smoking. But today we'll be speaking and highlighting the aspects which are concerned with the obesity, because I think that is what the crux of the today's program is. So I will be just mentioning a few more points about obesity. Obesity is an independent risk factor for stroke, and every increase in BMI above 20, every unit increase above 20 increases the stroke risk by 5%. And more than 30 BMI doubles the stroke risk. Because the obesity leads to more of atherosclerosis, there are more chances of ischemic stroke than hemorrhagic stroke in these patients. How does obesity lead to this increased stroke risk? Is by excess adipose tissue leading to inflammatory cytokines being released, which leads to a state of chronic inflammation, which is atherogenic. There may be insulin resistance, increased risk of hypertension because of obstructive sleep apnea, increased weight, etc. It leads to hypertension, and hypertension is the most important risk factor for ischemic stroke plus hemorrhagic stroke. There is endothelial dysfunction. As you know, endothelium is the most important vascular lining. It is very, very intimately connected with the atherosclerotic process, and anything which leads to endothelial dysfunction can predispose to all sort of vascular pathologies and illnesses. The metabolic syndrome which is associated with stroke, with obesity, also raises the risk of stroke. The accelerated atherosclerosis which is associated with obesity. So all these factors and many others lead to increased risk of stroke in patients with obesity. So as I was mentioning, that stroke is basically a vascular pathology. So basically you have to understand a bit about the vessels of the brain. So as you know, there are two carotid arteries, left and right, plus there are vertebral arteries which unite together, and they form the basilar artery at the lower border of pons, and they together form this circle of Willis. So anywhere the vessels are affected, then patient will develop a stroke. Whether it's the ischemic process or hemorrhagic process, that will depend on whether the vessel has ruptured or thrombosed. This is the lateral aspect of the brain, and here you can see this red part is the part which is being supplied by the middle cerebral artery, the yellow is being supplied by the anterior cerebral artery. These together are supplied by the internal carotid artery. The blue and the brainstem, they are all supplied by the vertebrobasilar system. So depending on where the stroke is happening, which vessel is getting involved, the stroke presentation will be there. So this is the brainstem. There are brainstem nuclei at various places. So depending on which part of the brainstem is getting affected, you will get the symptoms. So how does stroke present? So stroke presentation, most important thing to understand is the onset. The patient gets a bolt from the blue. Patient was absolutely fine few minutes back, and suddenly either he starts getting some difficulty in speaking, difficulty in holding objects, walking, they may lose vision, they may lose the ability to speak, they may get a seizure. So all these things can be because of stroke. So basically, stroke, the manifestation is not always hemiparesis. So we don't just consider hemiparesis to be synonymous with stroke. Stroke can present with visual loss, stroke can present with dysarthria, ataxia, vertigo, diplopia, depending on which part of the brain has become affected. The patient may just lose his ability to speak. The patient may just become aphasic, or they may start behaving abnormally. So depending on which part of the brain has become affected, the neurological symptoms will be there. But the most important thing is that's like a bolt from the blue. More than 3/4 of the strokes are ischemic strokes. So that's a good thing, because that is where all the newer advances are coming. Still, in hemorrhage, we are not able to do too many new things. So if a patient's, say, frontal lobe is affected over here, in the blue part, the patient may not get any hemiplegia. They just start behaving abnormally. On the other hand, if he gets a stroke in this part of the brain, patient will lose some sensations. There may be just, in the green part, this pointer is not working very well. In the green part, there will be just loss of sensation. If the yellow part is affected, then there will be loss of vision. There may be some memory problem if this part, temporal lobe, becomes affected. On the other hand, if brainstem is affected, patient usually present with vertigo, ataxia. They may present with hemisensory loss, hemiplegia, cranial nerve palsy. So the manifestations of stroke can be varied depending on which part of the brain has become affected, which vessel has become affected. So there are a lot of brainstem syndrome. Because of short of time, I will not be going into this thing. So ischemic stroke and hemorrhagic stroke are the two main types of stroke, and there are some clinical features which can help you to know which of this may be the most likely cause in this patient. So if there is normal BP, then there are less chances of hemorrhage, because most of the times hemorrhage is because of the hypertension only. But this does not mean that patient cannot have a hemorrhagic stroke with a normal blood pressure also, but there is more in favor of a ischemic stroke when your patient has a normal blood pressure. If there is too much of headache, again it goes more in favor of hemorrhagic stroke. Loss of consciousness early in the phase of the stroke, so then also it favors the hemorrhagic stroke. If there is history of TIAs, that patient was having some left-sided weakness for 1 hour, 2 days back, again he had yesterday, again he improved, again today he has developed left-sided weakness. So this goes much more in favor of a ischemic stroke, because in hemorrhage you cannot have TIAs. So these are some clinical, say, indicators by which, if you get history, examination, and these things you get, you may think whether patient is having hemorrhage or ischemic stroke. But still, it is very important to do imaging, because see, small hemorrhage may just present like a ischemic stroke. It may be clinically indistinguishable from a ischemic stroke. So don't just go by the clinical features, because in our city now, there is CT scan is available at 800 rupees only. If the patient is poor, at least get a CT scan done. Don't treat like that any stroke patient without doing an imaging, because suppose you think that it's a small ischemic stroke and you get the patient aspirin, etc., without doing any imaging, patient may be having a small bleed which can get aggravated. So it's suppose the patient is not affording, at least get a CT scan done in some government hospital. It costs hardly 800 rupees. But if the patient is affording, then definitely we should go for more imaging. I will be coming to that. So there are some stroke mimics also, which can present like a stroke, especially like subdural hemorrhage, migraine aura, Todd's palsy, etc. Because our focus is more on obesity, I will not be speaking too much about these stroke mimics today. But at the same time, I will still like to emphasize that because, see, our obese patients are more likely to get disabled. So we have to be even more careful and pick up this stroke early. Because if we pick up this stroke early, then only we can do the early intervention. So there is a acronym which you can remember very easily, which is known as BFAST. So what is BFAST stand for? Balance. B is for balance. E is for the eyes, whether there is loss of vision or some derangement, diplopia, etc. F is for face. Is there any drooping of the face? Is there any arm drift? S is for speech. Is there any problem in speaking? And T is for time. So if there's any problem with any of these, there's any loss of balance, problem with vision, speech, facial depression, arm drift, anything which has happened acutely, your antenna should rise up immediately, and this patient may be having a stroke, and the patient may be in the window period, and the patient has to be immediately managed, because brain, time is brain. The more the time elapses before the first intervention starts, more severe will be the ultimate disability. So earlier intervention, the better. So we have to now, if the patient calls you up, say, "Amna ardha kalak pehla to barabar hatu, amna hath chalto nathi," immediately think that there may be a stroke, and you intimate the radiology center or stroke center, and then you do the further management. Sometimes the stroke may be so severe that the patient may become unconscious at the outset. If a large artery is involved, brainstem is involved, then the patient may die at home only because of the severe stroke. Patient may not be able to reach home or hospital also. So stroke can be very severe to begin with if the patient is unconscious. It has become, so first of all, you have to see whether the patient is having a proper breathing, just secure the airway. Don't be in a hurry to bring down the blood pressure. 180 by 110 is also fine. Don't be in a hurry. If it is going beyond this, then only you can give a small dose of antihypertensive, because the patient may be having some stenotic lesion in the, say, carotid or the basilar, and if you bring down the blood pressure too much, then it will aggravate ischemia in case of a ischemic stroke. So it can aggravate the deficit. So don't be in a hurry to bring down the blood pressure in acute stroke patient until unless we do all the proper imaging. We see if the patient does not have a stenotic lesion, then we can reduce the blood pressure safely. On the other hand, if suppose the patient has a carotid stenosis, basilar artery stenosis, then we'll have to keep the blood pressure more than, say, 150, 160 to maintain the brain perfusion. If we decrease the blood pressure in such type of patient, there may be aggravation of the neurological deficit and the brain ischemia. So don't be in a hurry. So management also, because, see, usually we have the reflex of bringing down the blood pressure, so you will not aggravate the issue after this lowering of the blood pressure. So this is very, very important. Now what radiology we should be doing? So now, if suppose the patient has become unconscious, then it's better to first stabilize the patient. The general condition does not look good, then you first send the patient to a hospital where the primary management is done, and then you can think about doing some imaging, etc. And elderly people, you may get a lot of problems, and it's tough for us. Even see normal people also, while they have a stroke, we send them to a CT scan, MRI, they get a lot of problems. Many of them become anxious, they don't cooperate, and then we are not getting optimal quality of the scan also. In obese patients, many of these, the gantries of the MRI may be small, they may not fit in, so it may be even more difficult to do a scan of an obese patient. They may become claustrophobic, they may develop hypoxia. So all these things are more challenging in obese people. So what should we do when we have a patient whom you are suspecting stroke? When you're, suspicious of, the index of suspicion is very high that the patient is suffering from a stroke, then we should do a MR angio. That is the best modality which I will suggest, because as I told you, that stroke is a vascular problem. So until unless you scan the patient, your scan should be including both the brain imaging plus the vascular imaging. Then only you will get a complete idea what you are dealing with, how you have to rationally treat this patient. So if suppose on the other hand, you do just a plain CT. So with this plain CT, which is normal, does it exclude that the patient is not having a stroke? What do you people think? No, because see, this patient who has suffered from a stroke is subjected to a CT scan within few hours. The CT may be absolutely normal because it may not show the changes of ischemic stroke or hemorrhage in the ischemic stroke in the early stage. But on the other hand, if you do a diffusion MRI, there may be this type of picture which is seen, which is very, very large infarct is there, which is not seen in the CT at all. So MRI, especially diffusion weighted MRI, picks up the ischemic stroke very early. CT scan is good for hemorrhage. If CT scan is not showing a hemorrhage, then MRI also will not show a hemorrhage. So that is okay. But for ischemic stroke, MRI is the modality of choice. So now let's see a few cases. This is a 73-year-old hypertensive male weighing around 130 kg. He was from a low socio-economic status with history of ischemic heart disease. He was already on double antiplatelets, present with a right hemiparesis for last 1 hour. Reaches a nearby hospital, examined by a neurologist. He has a grade 1/5 power in right upper limb and lower limb with a gaze deviation to left. But is conscious, is preserved cognition. His BP is around 190/110. The patient is sent for a urgent neuroimaging, and scan reveals a left MCA infarct over here. So as I'm telling you, so in this picture, you can see that this is the diffusion MRI over here. This is the diffusion MRI. It's showing the infarct. And there is in the vessel imaging, you can see there is a occlusion over here where the pointer is there, over here. So, what do you think about this patient? What has he got? Yes. Yes, exactly. So, Dr. Saab has been very punctual in attending my talks. He has got all the answers. So, this is actually a stroke, ischemic stroke. But the important thing to understand is that you see there is a very large artery which is occluded over here. So this artery, the middle cerebral artery, actually supplies the whole of the pointer is not working. So this whole hemisphere actually is supplied by this artery. But you can see the infarct is only this small. So there is a part of the brain which is, we can call the penumbra, which has not got affected, but it is at risk of getting affected. So these are the perfect type of patients who require some sort of recanalization therapy, which can be either a chemical recanalization or a mechanical recanalization. So as I mentioned, this patient, if you don't intervene on time, so what will happen is this infarct will turn into this thing. So it will become a complete hemispheric stroke if we don't intervene on time, and the disability will be much more. Patient may die also. So we have to pick up these patients at the early stage and then do some therapy which can recanalize the vessels. So this patient, as I mentioned, was not a very affording patient. So what should we do in this patient? Now that we have got this imaging, give him injection dexamethasone, do carotid angioplasty, thrombolize the patient, give vitamin B12. What do you think? What we should do? Thrombolize the patient, exactly. Because say this patient was not very affording, so thrombectomy is not in question because they cannot afford that much. But this patient was then thrombolized. But the issue with thrombolysis in obese patient, as I mentioned, this patient was 130 kgs. So usually tenecteplase, which we are using now for thrombolysis, we are using maximum of around 25 milligram. So this actually becomes sometimes subtherapeutic because the body weight is so much that we cannot give 0.25 milligram per kg. There is a capping of say 25 milligram in this stroke patient. So what will happen is that the patient, because of the obesity, may not get good response to the chemical thrombolysis. Suppose a patient who was say around 70 kgs, if we thrombolize with 0.25 milligram per kg, may get a good response. But in this patient, because of the higher weight and this capping of the dose, we may not get good response, but there is no way out. The patient could not afford a mechanical thrombectomy, so we did a thrombolysis. Good thing was that the patient showed some recovery. His power started improving, and there was a episode of atrial fibrillation which was recording during the stay. So this patient was already having ischemic heart disease, developed atrial fibrillation, led to a cardioembolic stroke. His power was at least grade 3/5 at the time of discharge, and he was put on apixaban along with clopidogrel for the prophylaxis of stroke plus ischemic heart disease. So all this, rationale of the reperfusion therapy is because, see, as I mentioned, in this stroke, there is a part of the brain which is irreversibly damaged, which is this black part over here in the center. This is the umbra, which dies within few minutes of the onset of the stroke. So any early intervention also will not be able to save it. But there is a lot of area which is surrounding this, which is in the gray, light gray, dark gray. So these are all injured but not dead. So if the timely institution of recanalization therapy is made, then this part of the brain can be salvaged, and this is what will make the patient disability less. Because the more larger the size of the brain involved, more will be the disability. So our job is to reduce this amount of infarcted tissue and do by some early interventions, either like thrombolysis, which I just mentioned, and there are other modalities also. There are some contraindications from thrombolysis. I will not go too much in detail over here. I will now switch to the other case. So this is one more case in which we'll see there is some other therapy which has been done. So this is a 120 kg female. She presents with left hemiparesis with power around 3/5 in the last 1 hour. And a scan is done, which is again showing, see, as I mentioned over here, in the last case also, this time the infarct is on the right side. And you can see the infarct is over here. And if you can see, the artery is occluded over here. So there's again a very large part of the brain which is at risk of getting infarcted. So there's a large part which is in the penumbra, and when this penumbra can be salvaged in time, then patient can have a good recovery. So this patient was not having any economic issues. So what should we do now? Start injection DEXA, thrombolize the patient, do mechanical thrombectomy, do carotid endarterectomy. What do you think? Thrombectomy, exactly. Because see, as I mentioned again, this patient is also 120 kgs. So in this type of patients, thrombolysis, again we have to use a dose which we don't know how much effective it is going to be. Plus, thrombolysis itself may not be a very good idea for a patient who has got a large vessel occlusion. So large vessel occlusion sometimes are not recanalized after giving tenecteplase or TPA, etc. And so this patient underwent what is known as a mechanical thrombectomy. So this patient was subjected for a DSA, which again reveals a M1 occlusion, and this patient actually has been treated at our hospital, and this is what the DSA was. So you can see in the first shot, there is no flow in the right MCA, but then later on the guide wire is passed, and then later the device is passed, and then we do the thrombectomy. So after doing the thrombectomy, we take a check shoot again, and then you can see the beautiful reperfusion. This is a procedure being done. And then the shoot. See, you can see, this is all the artery has now started filling up. No, it's done under a cath lab. The CM will want to do, because see, especially for brain, the CM is not so good. So this is how the sound is not coming. So this is how this procedure is done. So this is a patient who has got a thrombus in the middle cerebral artery, and this patient has been put on the cath lab. And of course, the obese patients, again, it is difficult to manage all these things. But it's better than chemical thrombolysis. We pass the catheter, go up, and then pass the device across the thrombus, and this device opens up, and then it brings it out. So there are multiple type of devices. Some have got like a basket, some have got some suction. So all these procedures are done. I think it has become mute. I'm sorry for that. There was a beautiful music playing in the background. So this is how the device is passed, and then there is a net sort of thing which is now inflated, and this catches hold of the thrombus, and then the thrombus is taken out, and there is recanalization of the artery, and the blood flow is restored, and that part of the brain which suppose had not been reperfused would have become dead or ischemic. Then that part is reperfused, and this leads to neurological recovery. Those neurons don't die. So that is how these patients improve. So this was about what are we doing in the acute phase when the patient reaches to us in the window period. The window period for chemical thrombectomy is usually up to 4.5 hours. In selected cases, we can go beyond this. And ideally, the earlier the better. The mechanical thrombectomy, we have a longer window period. We can do up to 24 hours, but those patients who undergo these procedures as early as possible get a better outcome. So beyond window period, what else we can do? See, antiplatelet therapy, as all you know. Sir, we have 2 minutes. 2 minutes, okay. So this is how the antiplatelet therapy, the problem is again with obese people, they have higher platelet reactivity, so we may use agents like ticagrelor, etc. And these patients of obesity have got some own type of challenges. I will just skip through some of the slides because of the, so in obese patients, nursing of the obese patients is very, very difficult. The patients develop bed sores, etc. They may develop UTI, they may develop a lot of respiratory issues because aspiration pneumonia, they have obstructive sleep apnea. So these patients are a bit more difficult to manage as compared to a patient with normal weight. But these things have to be managed, and it really puts a strain on the hospital resources because 2 or 3 ward boy IFI may be required for one single patient, which may lead to a lot of patients' dissatisfaction also. So this was in short my presentation on stroke. Next time, my question to you is, next time when you get a call that a patient is suffering from slurred speech or weakness in the holding of objects for last 1 hour, what will you do? As the clinic is closed now, call him in the evening, tell him to take ORS, it will make you feel better, give him injection, DEXA and wait, or you will act fast and send him urgently to a nearby stroke center or hospital. Ah, very good, very good. So we are all becoming fast. So this is a New Wins Hospital, which we have started recently in Borivali in the last 2 years. It has got all these facilities of treating stroke patients under one roof. We have got in-house CT scan, in-house MRI, in-house cath lab, in-house OT, everything we are doing over here, and our door to needle time is fantastic. So basically, see, as you know, what happens with stroke patients, see, brain attack is different than heart attack. Heart attack, you can just diagnose on ECG. But for brain attack, not only window period is very short, but you have to do imaging also, you have to do intervention also. All these have to be done in a very short period of time. So what happens is that a lot of time gets wasted in getting an MRI done, then calling a neurologist. So we have got all these things under one roof over here in New Wins Hospital. We are doing excellent work, and then we have thrombolysis, mechanical thrombectomies are happening routinely at our hospital. It's a nice place. I will invite all of you to once visit it if you are not already visited and see the work which we are doing. Thank you so much, KMA. Thank you, Dr. Utpal Seth, Dr. Aarti, Thorab, for inviting me and asking me to give a talk which is on a subject which is very close to my heart. And I hope you have found my talk informative and practical and useful. Thank you.
Thank you so much, sir. So you said we are saving time on everything, but you forgot to tell one thing. Most of the time we spend explaining the patients ki ye karo, wo karo. So it's just on a light note.
The hemiparesis, then it becomes very obvious. But if just they may say develop some speech problem or they develop a bit of dysarthria, some clumsiness, then they may not realize what they are suffering from. So it is also a very important, I think, aspect which you have highlighted, and there is how, where you people play a big role in telling the patients that it is really an emergency, it's a very serious thing, don't ignore it. Your relationship with the patient also and how you explain it also matters a lot, and that can save life.
Thank you, sir. I request Dr. Kaustubh, Dr. Purvi to please guide sir towards the KMA's wall of the fame for the felicitation. Sir, please. I also request the team, AV team, to play the quiz. So, friends, ready? The quiz is there on the display. You have saved your KMA numbers. Please feed the right answers. We have 30 seconds to feed in the right answer.